So it's now time to move on to our first panel. And we're going to be looking at how the NHS needs to restructure and retain its staff in the wake of the continuing challenges of COVID-19 as it prepares for a winter crisis, as it works its way through this second wave and also looks forward into the future. There was a workforce crisis before COVID-19 ever came along, with A&E waiting times the longest on record, and many patients struggling to access essential hospital services. There was a shortfall of 100,000 staff within the NHS, and that meant that medical cover regularly went unfilled and stress-related absences amongst the staff rose. But even as we get a handle on this virus, a backlog of non-COVID patients has built up with serious conditions. So the challenges of the second wave, the winter crisis, it's all there looming over the NHS. So what does the NHS of the future need to look like to meet that patient demand and demand going into the future? How do we challenge some of the inequalities in healthcare and provision that were so brutally exposed during the COVID-19 pandemic? And how do we support that exhausted workforce who we so happily and proudly clapped for, but in effect are working into the ground? Is that just tough because that's what they signed up for, or can we perhaps do a little bit better? Delighted to be joined to discuss that and more, I'm sure, by Richard Murray, who's the Chief Executive of the King's Fund, by Anita Charlesworth, who is the Director of Research and Economics at the Health Foundation, and by Danny Mortimer, who's the Chief Executive of NHS Employers. Good morning and welcome to all of you. Let's start by looking at staff. Nursing and midwifery are the standout shortages, but 100,000 in anyone's money is a massive gap. Danny Mortimer.
It is, Alastair, and I think, as you said, the problems that we faced were there before the pandemic. The response we've seen from the recent spending review, and Anita is able to talk far more expertly than I about this, is insufficient. I think there is a sense in which we still need a significant stepping up of investment in the education pipeline. Amongst those 100,000 vacancies that you've described are a huge number of degree qualified staff, and those staff need teaching and educating in our university sector, and we need to see significant investment both through Health Education England and through the Office for Students in encouraging people to come and join us. And I guess that's one of the positives that we are seeing, is a real increase in interest in working in health and social care because of the profile that it's had during the pandemic. But we need to capitalise on that, and we need the government to be prepared to invest longer term in, as I said, increasing that pipeline of
okay, I'm going to come towards investment at the end, as it were, having laid out some of the challenges. But I note that point very clearly, and let me come to Richard, because one of the things that struck me, Richard, in this is that a key lesson of the COVID-19 pandemic is that you can't do the rest when you're doing a pandemic.
Absolutely right. And of course, one of the responses when the pandemic first hit was to shut down most of the services that could be shut down, to devote everything onto the pandemic. And I think that's one of the lessons we've learned, is to try and keep routine services going for as long as we can. I think one of the other things we've learned, though, to touch on the workforce issue, is for the NHS to look to a wider group of partners as well. One of the strengths we've seen here is some of the much closer working between people in the voluntary sector, outside of hospitals, sometimes inside hospitals too, that's helped people stay well and stay connected, help them get out of hospital and stay home. So as difficult as the situation within the NHS is, I think there are some hints here about the way in which the NHS, by working with that wider group, I mentioned the voluntary sector, local government, social care employers too.
That's a crucial point, because we all know that, you know, whether it's the Women's Institute bringing around tea trolleys, or whether it's local children's care groups raising money for, I don't know, special needs maternity and postnatal wards and what have you, that's because it's good men and women doing good stuff. Are you suggesting that needs to be more formalized because we've learned we can only do it on the basis of folk doing right stuff? Or do we just hope that good folk are still out there?
You do hope that good folk are still out there, and of course they are. And I think we've seen through COVID just how much willingness there is to try and help the NHS, but also to help their neighbours and people who are in their community. What we want is to try and build up those links between the statutory services like the NHS and often local government and those groups that try and work together as one. So those groups will know when patients are coming out of hospital. They'll have a better sense of who might be vulnerable.
But my point being retaining the voluntary word at the heart of it rather than formalizing it.
Yes.
Okay.
So you're drawing
Anita,
on the enthusiasm of
let me bring Anita in, because Anita, you've written that without reform and rethinking, and Richard just spoke eloquently to the rethinking, and Danny started us off talking about a degree of reform, but you have said without reform and rethinking, that shortfall of 100,000 staff will double, and you say training and pay are key.
Absolutely, and I think we have a opportunity at the moment where obviously people have seen how important the NHS is. The numbers applying to key roles like nursing have increased significantly. And on the back of what happened this summer with the A-levels, we've got an increase in the numbers training to be nurses, training to be doctors this year. We need to make sure that that isn't a one-off blip and just this strange COVID year, but that's a changed trajectory. But it's not just the degree level occupations. And we also need to think about how the NHS and the social care system can make a contribution to solving some of the wider problems that COVID will have created. Opportunities for young people in employment are going to be significantly hit by the recession that will go on beyond this year.
When you talk about conditions, I mean, I can understand the retraining bit and the rethinking, but conditions of employment.
So for social
you don't have a staff shortfall unless people resign, walk out, don't sign up.
So there are a couple of different things. So we've got in social care in particular, we've got an issue where we have a workforce that are very low paid, often minimum wage. Very high rate of 0 hours contracts, so a quarter on 0 hours contracts. There's quite a bit of research now emerging that those employment conditions in social care were associated with some of the spread of COVID in our care sector. So that employment model didn't work for a large number of the staff who worked in social care, and also left us vulnerable when we had the pandemic. And social care workers have had some of the highest mortality of any group in the workforce. So for all of those reasons, we do need to profoundly rethink social care terms and conditions. And it's over 1 million people who work in social care. And also I want to add into this, there's a national issue of shortage, but there's also a really important geographical dimension to some of the shortages. And COVID-19 has impacted disadvantaged communities most. And in many cases, disadvantaged communities have some of the struggle most to recruit and retain healthcare workers. So for example, there are fewer GPs per head of population when you adjust for need in disadvantaged communities compared to more affluent communities. So we need to think about this nationally, but we need to also understand the geography of our staffing shortages.
Let me hold that thought. I'm going to come back to you, Danny, in a moment, but I just want to bring Richard in because Anita has spoken there mainly about nurses and care workers. But Richard, your research has pointed out that nearly half of all GPs will either retire early or go and do something else as a result of the experience of the last 9 months. And you suggest at the King's Fund that a new model of general practice is required. So there we have Anita talking about nurses and care workers in crisis, as it were, and your King's Fund saying it's not that different in the GP sector. Will a new model of GP work solve that?
there is some reasons to be optimistic on the GP side. Certainly not in the number of GPs. That's the real problem. And of course, GPs are the cornerstone of the way the NHS works, and where people get most of their care is from general practice.
As long as they've got a telephone and a laptop or a pad or something like that.
Well, indeed, or don't mind standing outside of the practice waiting in the wet.
Yeah, and if you're 65 or 70 living in fear of your health, and somebody says log in and I'll Zoom you at 9:20, it's not what they grew up expecting.
What they grew up expecting. We have to remember that hopefully, as COVID recedes, some of that face-to-face work will recover again. And we're still in emergency mode at the moment. What we are seeing in general practice is the large-scale appearance of new professions. So many pharmacists, many physiotherapists, much of the work that we see going through general practice can be done by other professions. Also link workers helping tie together some of that voluntary work with patients coming through the door who may have social issues as well as health issues. It's a really tricky thing to do because you're redesigning the way that a very long established.
All right, it can be done. I'm going to stop you there again, only because of time. But you set up Danny perfectly as the chief executive of NHS employers, because Danny, the NHS has, as it were, it had a long-term plan, and then it had the people plan, and most of that's been pretty well paused because of COVID. And as Machiavelli said, fortune is the arbiter of half our affairs. Maybe that's a bit of luck. The government have pledged to more GPs and pledged to more nurses, but everything's on hold. When you hear Anita talking about the role of care workers and finding perhaps a new type of health worker to come in there somewhere, and you talk and you hear Richard talking about a new model of work for GPs, does that chime with your thinking at the NHS? Or, I mean, you're aware of those arguments, but are you singing from the same hymn sheet now, do you suppose?
Yes, and it chimes both with how people are thinking, but also how people are working, and were working before the pandemic. The changes that have been described in primary care are still being distributed, but are being implemented in many GP practices. The use of technology alongside face-to-face appointments, Alastair, I think is a positive, and the scaling up of that will help people access healthcare teams where they need to. But it is both and, or it's a both and. We need to think very differently about how we work, and there are some fantastic examples of that during the pandemic in terms of organisations running their services very differently, and staff themselves generating ideas to do that. That's brilliant. We need to see investment in social care, particularly because that's a really important partner for our teams in the NHS. We care for the same people, particularly our elders. And we also need to see that kind of investment and capitalisation that Anita described of interest in the NHS. We need to do all of those things, and we need to redistribute some posts out of some of the more prosperous areas, particularly London and the South East, where we see a greater concentration of doctors compared to where I'm talking to you today in the Midlands. You know, all those things need to happen. It's a big, complex endeavour. But the NHS isn't passive in this. We're not just sitting there saying, well, invest in us, give us more people. We are thinking very, very differently about how we deliver services. And I do think the pandemic has helped us in some ways think some fairly unthinkable things, make some fairly radical changes that we won't reverse now in terms of how we work and deliver care.
And as I said to Nadeem Zahawi when he did the keynote address, let me ask you, Danny, as well. You know, working with people like Simon Stevens and also the superstars that we know from the Number 10 Downing Street press conferences, although Simon turns up there as well occasionally. Is there a grid? Is there a time scale? Is the NHS collectively at your sort of level now saying, look, you know, we've had 9 months of this, we've now learnt the lessons about nursing. I'm going to come to care on the next panel, but you've introduced it and Anita spoke about it, but nursing, care workers, GPs and what have you. Here we are, you know, nearly halfway through December. By the spring of next year, we'll have the first draft of you know, son and daughter of the long-term plan and the people plan. Is there a time scale, a grid?
In simple terms, the NHS wants to, you know, carry on where it left off. I think and deliver the long-term plan. The complicating factor now is the impact of the pandemic. It's the delays that have been caused, the massive growth in our waiting lists. It's also the additional demands for our services. We're only starting now to understand what COVID means in terms of longer term impacts, the so-called long COVID kind of set of symptoms and conditions that people are having. We're starting to see growth in demand for mental health services. That will be exacerbated by the recession that we are entering. We know that from previous recessions. So those are the complicating factors. The other two complicating factors are that the long-term plan that was announced a couple of years ago was incomplete. There was no investment in capital. There was no investment in public health. There was no long-term investment in the workforce. And without those things, the ability of the long-term plan to be delivered, or the next iteration of the long-term plan, it's pretty tough, to be frank. And similarly, successive governments of all colours and combinations of colours, have promised a plan for social care, and that also makes it more difficult for the NHS to do what it needs to do.
We're going to drill into social care in considerable detail in part two, as it were. But before bringing Anita and Richard back in to comment upon what you've just said, Danny, let me press you on what I think is a central point. You said there was the long-term plan and the people plan that was put on hold, quite rightly, because of COVID-19, because life-saving and health protection became the absolute priority, traced back to March and since then. I understand all of that. Are you telling us this morning that come the spring of next year, all of that work will simply be reactivated? Because what I'm sensing from Richard and Anita is you need a fundamental rethink. You need to redefine what a GP does. You need to redefine what a nurse does. You need to redefine how nurses work with care workers, et cetera, et cetera. Is all of that in those two plans, or are you going to have to get your pens out again?
Those things are in those plans already. And the desire to kind of continue implementing the long-term plan was resumed in the summer. Our members were contacted and told to step back up services.
Fine. That couldn't be clearer. First of all, Anita, are you happy then that the issue, Danny's just said they are within that plan. So are you confident, Anita, that when we get back to working on that, that it's the correct agenda and the correct ambition?
Direction of travel is absolutely correct. I think I want to re-emphasize the point that Danny made, that actually a lot of that, though, was not resourced before the summer. And actually we were expecting with a new government, if you remember back, we were at the beginning of a new government who were going to lay out their agenda for this parliament. And that was going to include how they were going to resource enough doctors, nurses, other healthcare workers. There are some things that do need to change as a result of this. As Danny said, we've got new areas of demand. Mental health, we're already seeing significant numbers, all the long COVID. We've got a huge backlog of waiting. Staff are exhausted, but they've shown that they can work really differently. So we do actually have a really critical time to next year to convince them that it is worth staying in the NHS and going on this journey, because actually it won't always be that they're completely overstretched and drowning in their workload. And that's probably the most important issue for them.
So if you like, before bringing Richard in, Anita, let me be crystal clear for the folk good enough to join us, make sure I've got it and that they've got it, that you too are content that Danny and the NHS team reactivate the existing plan, long-term plan and people plan. But the one thing you say as a standout that is in need of highlighting is mental health.
But also the funding for the additional...
I'm not going to talk about funding yet. That's my last subject. Save your beer voucher arguments for a moment, but that's crucial. So that the paragraph the chapter on perhaps mental health either needs to be added or needs to be rewritten. Richard, are you broadly content with the papers as they exist, or do you think there's something that's been left out or that needs greater emphasis? Okay, yeah. Danny, come back in on that. Mental health, better integration, and don't forget that it's not only hospital appointments that have been delayed and that there's a build-up and a backlog, it's also in primary care.
And Richard is absolutely right. There's a whole set of issues that didn't exist before the pandemic that will challenge the plan, that challenge that direction of travel, but actually, if anything, make that direction of travel even more important. And I think that the experience of the pandemic has accelerated that collaboration and integration that Richard's described. Actually, we've done that. We've seen the acceleration also of the use of technology. I think the other challenge that the pandemic has given us, though, is that we do need to think much more radically about the experience of inequalities. The fact that actually poverty and ethnicity became key risk factors in terms of the disease, in terms of the virus, have shown the NHS that it needs to do much, much more in terms of addressing those issues. The NHS Confederation that I run at the moment is establishing the Race and Health Observatory, for example, to try and target in particular action to improve access, outcomes and experience for Black and minority ethnic communities, and that's really important. But there are other areas as well of health inequalities that were referenced in the long-term plan, but that probably is the area that will have the most radical overhaul, most radical thinking, just because the virus has actually shown us the scale of the challenge there is there in terms of those very different outcomes for different parts of our population. And that's probably the area above all that we're gonna have to target.
But also, just to underline that point, Anita also observed not only the challenge to certain ethnic groups because of the way in which people live, the average size of family units, et cetera, et cetera, et cetera. Anita also pointed out that per capita, there are fewer GPs in poor areas of the United Kingdom than there are in wealthy and comfortable areas of the United Kingdom.
So there's a few things there. Absolutely, there are those issues about how we've distributed some of our workforce over the years, particularly medical workforce. You see the phenomenon that Anita described in general practice. You also see it in terms of hospital services as well. Much greater concentration of trainees and senior doctors in London compared to other parts of the country, and that is an issue for us. I think the thing we have to accept in the NHS is that we are we've been better at designing services for people who look like the four of us than we have for and have lifestyles like the four of us, than we have for the diversity of our population. So actually, if you are poor, you find it harder to access our services. We know that many of our ethnic minority communities find it harder to access our services for all sorts of reasons, and that just speaks to the fact that we haven't designed our services well enough. We haven't thought carefully enough about how we provide services so that actually those communities, whether it's a poor white community or an Asian community in Leicester down the road from me here in the Midlands, or an Afro-Caribbean community here in Nottingham where I live, that actually those people have far poorer outcomes than I do as a white middle class man. And that
let me butt in on you, Danny, just because I've got my little WhatsApp group here going and being fed questions from people who are calling in. But this is an anonymous question, but it chimes worryingly, I think, with what you were just saying there. Hasn't the whole COVID experience demonstrated the failure of centralized planning? I mean, in a sense, what you're talking about there, the need to address the per capita distribution of GPs and GP practices to poorer areas. I mean, is the NHS up to doing that?
So, I mean, to answer that question, we do have a very strong central kind of direction of the NHS, and that redistribution of medical posts, for example, needs that kind of national intervention. But actually what we do need to see, and I think what we've seen during the pandemic, is a much greater ability for local leaders to address the problems that their organisations, their communities face. We are, in my experience, the NHS, 30 years and counting now, we are an increasingly regulated, increasingly overseen service from central organisations. And actually, part of the direction of the long-term plan is to try and ease that, and that is needed more than ever, because we do need to let those people who are leading and delivering services within the NHS and their colleagues in local government and elsewhere, we need to give them much greater discretion, much greater authority to make the changes that will benefit their communities, because that cannot be done from a central regulator or from central government.
Okay, I've got one more general question, and then I'm going to commit the last 10 minutes or so to the investment issue. And the penultimate question, and I'm going to come back to you in a moment, but I'm going to go back to Richard and Anita with this one, and then again ask you as NHS employers, Chief Exec Danny, to comment upon what they say. Anita first, immigration. The reliance upon the NHS in many sectors of skill, but predominantly nurses and GPs. Will that go on? Will it be made more difficult with the measures that Priti Patel has introduced, and does that become trickier or easier post-Brexit? How, in your view, Anita, does the whole immigration dimension impact upon looking at a better and more fit for purpose NHS post-COVID?
So I think over the medium term, we need to increase the number of domestically trained staff so that we are less reliant on overseas workers to staff our NHS. That doesn't mean that we should have a closed system where we only ever employ people who are domestically trained, but we shouldn't be a net importer overall of staff on a long-term basis. Having said that, though, it takes so long to train doctors and nurses that the only way that we're going to be able to staff our NHS over the next 5 years is to maintain international recruitment. And we, with the Kingsford, have assessed that we need about 5,000 nurses a year. Now, prior to COVID, we had started to see numbers increasing. Obviously, COVID, with a lack of migrant flows, it has impacted that. It's really difficult to know what will happen. And I don't think the immigration rules are necessarily the most important factor. COVID has changed, I think, for many people around the world, their view about how small or big the world is now. And you may see many people wanting to be closer to family. And so we may see a wave of movement after that. They're also, though, going to be a global economic hit, and people are going to be across the world in search of good work. One of the most important factors, though, for our ability to recruit overseas workers and retain them just as much as domestic is what's the experience of working in the NHS like? How good is the pay in terms and conditions? And does it feel like you can do a good job? So actually, when you come back to recruitment and retention, whether it's domestic or overseas, the number one important thing we need to make sure is that if you come and work in the NHS, you're supported to do a good job and you get a fair pay for that work.
I'm going to stop you on that, because that point has been made, and I'm no harm in making it again. That's the way these things occasionally work. But I'm going to take from that your main point being that self-sufficiency should be an ambition. We were moving in that direction. COVID knocked it back a little bit, but we should continue to try and aim for that. Richard, is that your view as well?
If I've got a caveat, it would be this isn't the first time UK policymakers have aimed for self-sufficiency in either a medical or nursing workforce, and here we are actually more reliant than ever on them coming in. So I think it's exactly the right way to go. The world is becoming rather more unsafe, and the world's becoming more competitive. So it's not only us that are in a nursing shortage, so it's the United States and most other developed countries. And so the world's going to get tougher to recruit from. In the next few years, though, we've got to recognise that some of the answer on the nursing workforce has to come from international migration. If it doesn't come, then it's going to be quite bleak. It's one of the things that we can do rather more quickly. And so whatever Priti Patel does needs an NHS kind of sense test against it to make sure that it doesn't get in the way of bringing people in easily, quickly, and giving them that good experience that Anita talks about, so that they actually feel that they're wanted rather than unwanted.
If they come here, it means they're not serving the country where they grew up and where they live and where their families come from. I've heard that argument made in many quarters. Does the King's Fund dismiss that argument, or is it sensitive to it?
Not at all. We've got overseas aid obligations, perhaps not quite the ones we had a couple of weeks ago, but there needs to be an ethical approach to employment. That might mean sometimes that people come here, they also get some training while they're here, and then sometimes go back again.
Sure.
And it should be done with the agreement of the country that they're coming from.
Thank you for that. Danny Mortimer, self-sufficiency is a reasonable objective, but you've always employed folk from other countries, and perhaps you will have to continue to do so. How close do you think the NHS can get to self-sufficiency?
way to go, to be frank, Alastair. And again, I can reassure
But
the audience.
Is it a noble objective?
Yes, I think it is. I think it is the right objective, albeit with caveats that we clearly do need to bring people in from elsewhere in the world. The experience of the vaccine being developed in Germany by a couple of Turkish scientists and being developed and tested by teams right across the world shows that life sciences aren't kind of developed in isolation in particular communities. And the UK, as one of the leading nations in the world in terms of life sciences, needs to be able to bring people in to work in our teams. And the history of the NHS has been about men and women coming to prop up our primary care service from the Indian subcontinent, about women coming from the Caribbean and Ireland to train as nurses in the 50s and 60s. And we see men and women coming from the Philippines and India again more recently, as well as from our neighbours in Europe. Sure. But yes, we should aim for greater sufficiency. And again, that speaks to this need for a better plan. The reason we got ourselves into the mess we got ourselves into over this last 10 years is that actually governments weren't properly committing to long-term plans and long-term financial settlements to the NHS. And there was this almost wild assumption that somehow the NHS would be smaller. In the face of an older, more sick population, somehow the NHS would be smaller and would employ fewer people to look after them. We thankfully accepted that that's nonsense, but that was a consequence of the fact that we didn't have a proper plan for the NHS. And I guess it reinforces also the need for a proper plan for our friends in social care as well, because we can't repeat the same mistakes in terms of social care investment and the social care workforce.
Let me sum up on that very, very important chunk, that essentially it is your belief, Danny, that the long-term plan and the people plan are fit for purpose, and the principal, not criticisms, but additions, as it were, that you got from, interestingly, the King's Fund and the Health Foundation, both very powerful, articulate, well-informed lobbyists, as it were, is a clearer grasp of the damage that has been done to folks' mental health as a result of the pandemic, and a preparation for that in the future. The need to have greater integration wherever possible in dealing with the backlog that's in hospitals and in primary cares, and that the ambition of self-sufficiency in terms of NHS staff is a noble one, and one that is, however, a work in progress, but that is what should be the plan. So I'm going to come to the final chunk then, and I'm going to ask Richard Murray first from the King's Fund. In your view, does the NHS see Her Majesty's Treasury as being a bottomless pit of money that the NHS just keeps going to without ever fundamentally questioning its efficiency and its modus operandi? Because that's the impression it's often left with out in the public at large.
I don't think the NHS thinks that. And again, we've just spoken about a decade where NHS spending largely didn't keep up with demand. So as bottomless pits go, it will help pretty awful for many people working in the NHS. And we've just spoken about the workload issues that staff are facing. That's because there aren't really enough of them to deal with the patients that are there. Part of the challenge here goes to what you think the NHS can do. And I think Danny said it exactly. The NHS cannot provide good quality care to a population that is getting bigger and getting older and sometimes getting sicker. It can't do it on the same budget, on the same number of staff. So if you start from thinking, well, the budget shouldn't go up at all, well then yes, the NHS is going to keep on coming back. It can't do anything else. If you recognise that, like so many other things, actually spending goes up over time, you can then have a more sensible conversation about, well, what should the spending levels be? What amount of care are we going to buy? What kind of quality of service do we want? Starting from the assumption that the NHS keeps on coming back because the budget keeps on going up. Well, the number of people in the country keeps on going up. So of course, the budget for the health service is going to go up as well. It's about how quickly it rises.
But if you take a fascinating comparison, the Ministry of Defence, they have a regular defence review where they think fundamentally about what they try to do. And we no longer think in those terms about the battlefields of Northern Europe and tanks rumbling towards one another, some with red stars on them and others with stars and stripes and Union Jacks upon them. We talk about cyber war, we talk about the Chinese, we talk about intelligence coordination, et cetera, et cetera. When was the last time the NHS had the equivalent review of what you actually do? You mentioned in passing that GP work is fundamentally redefined. Anita talked about the need to think about a fundamental new worker, a type of worker, somewhere between care worker and nursing in the NHS. But doesn't the NHS need to have the equivalent of a defence review if it's to keep going and taking more money from the Treasury?
To an extent, that is what we saw in the long-term plan. It didn't do everything. It did do some elements of rethinking what that model would look like. And that's where some of the changes in general practice are coming from. I think what is valid, though, is that the world has moved on because of COVID, both the challenges the NHS is facing, but also the level of ambition about how quickly the NHS can change. I think, like many people who've worked with the NHS for over many years, sometimes the pace of change, whether in new technology or new services, sometimes seems to be slower than people would hope. But what we've seen over the last months since March is sometimes changes at breathtaking speed. And I think we're about to see it again on the vaccination programme. What it's shown is if you get the ingredients right, the NHS can change at enormous pace. I think it's that ambition we need to come back to think again for the next few years.
Let me put the same questions to you, Anita, but adding in that point that Richard brilliantly made there at the end, that you can be cleverly inventive, whether you're dealing with the vaccination program under Nadeem Zahawi or whether you're talking about Oxford University working with AstraZeneca, whatever it might be. But you've got to bank those changes. You've got to bank those experiences and not simply move on to the next phase.
One of the things that we see across the NHS time and time again is pockets of outstanding innovation and people pushing forward and doing incredible things. What we often struggle with is spreading that innovation consistently and quickly enough across the system. And it's one of the paradoxes of a National Health Service that people kind of assume that it'll be broadly the same everywhere, and it differs quite significantly. And too often what we see is pockets of little cottage industries. One of the things I want to come back to, though, is your point about defence review, because I think this has reminded us again and again that actually having clear strategies that are really well aligned is absolutely critical to the NHS. And a couple of years ago, the House of Lords had a select committee on the sustainability of our health and care system. And they recommended that actually one of the paradoxes of the NHS is that we've had it for over 70 years, but the way we manage it is actually on an incredibly short-term time horizon. And we plan our workforce to the extent that we do, separately to the way we plan our physical estate, separately to the way we plan our services. And what we need is some kind of body, a bit like the Office of Budget Responsibility that does this now for the economy, which is a bit independent, which doesn't just, look at this every 10 years, but on an ongoing basis is looking at how our population is changing, how new technologies are changing, because, the vaccines have shown us, what used to take 10, 20 years in terms of development, we've done in a year. And that is exceptional, but actually innovation time horizons are shortening all the time. And so we need an ongoing capacity to think long term, but act fast on the long term and across all the different areas that we need to in the NHS. And I hope that rather than just taking this as a moment and doing a one-off, we'll actually learn from that and embed better planning. And the shortage of capacity in the NHS was actually one of the things that made it so difficult when COVID hit to manage that well, to sustain other services. And when we look across different countries that have taken the biggest economic hit are countries that have taken the biggest health hit. So the Treasury, it's the economy or it's health argument is utterly false. A really well-functioning NHS that's really efficient is not a drain on our public finances. It's part of being a successful global economy.
Final point before I bring Danny in to comment upon what both you and Richard have said, but let me press you, Anita, on the very point that Richard was making. GPs have learnt to do things in a different way, force majeure. They had to because of COVID-19, but they have now become more accustomed to using laptops, pads, smartphones, etc., etc., etc. That's more cost effective as well, but it isn't necessarily what a 68-year-old woman who's been widowed wants, or a young mum who's living on her own bringing up a child. If that is the way forward and it saves money, it requires a huge education program as well, because we pay the bills.
Absolutely, although quite interestingly, the one service that for over a decade has been entirely phone or online is actually the pension service. Yeah. So the first government service that closed its offices, I'm not suggesting GPs close their office, by the way, but it is a paradox that we do talk a lot about, and digital literacy is really important. And I'm not, but it's about the support you provide, and it can't be just digital. And we are slightly in field hospital mode at the moment. You know, we've had to innovate very rapidly. And we do need to make sure that we learn from that innovation phase, but we do actually very carefully now adapt. I mean, people are talking about this. We're all sat in our bedrooms or whatever at the moment, home working. Most people are saying, I don't want to go back to 5 days a week in the office. But most companies are also saying, I don't want to be 5 days a week with all my staff at home either. It's that horrible word hybrid. And we've got to create our new normal, which is the best of both.
Okay, Danny, lots to come back on there, but let me start off by putting that basic question to you, whether there is a sense, because what you do is literally vital, not metaphorically, but literally vital, that there is a sense within the NHS, we'll just go and pick up the blower to Rishi Sunak and the money will keep rolling in, that you've learned you now have to trade efficiency, effectiveness and imagination for cash?
I think the history of healthcare is a history of innovation. The history of my career, the things I've seen in my career are enormous innovation. People stay in hospital now for far fewer days than they used to when I managed an orthopaedic service in the mid 1990s. So I see my clinical colleagues innovating at enormous pace, actually. Yes, it could be quicker. Yes, we'd like that innovation to be spread more quickly, but actually the productivity of the NHS far outstrips many of our private sector comparators, actually, and the pace of innovation far outstrips that. And you can see part of that success in the fact that we're all living longer. In my lifetime, my life expectancy has increased by over 10 years. And the simple fact is that successive governments, and it is successive governments, this isn't about Mr. Sunak, it's about a succession of his predecessors as well, have failed to keep pace with that. So that suggestion that Anita made about actually having something within government that's dedicated to taking a long-term view around health and social care, to my mind, to our members' mind, is essential. What we see, what we saw throughout the 70s and 80s and 90s is a complete lack of investment in the NHS. We then saw a spurt from Tony Blair in the early noughties. We then saw it being paused for another 10 years. We then saw, or longer, 10 or 20 years. We then see a little spurt from Theresa May a couple of years ago, which is incomplete. No capital, no public health, no money for education, no money for social care. We need to stop that. And that's, the NHS is doing its bit. Our clinical teams are innovating, working differently. They've done it at a scale in this last 9 months that I've never seen in my career, but they are constantly finding ways of looking after their patients in better and more effective ways.
And what's your view on my notion of a defence review equivalent, a health review? And as Anita said, then maybe also the equivalent in parallel to that of an NHS Office of Budget Responsibility. So you have an objective assessment. This we can do, that we can't do. This we can do more productively, that we can't do. And here are able men and women who are objective judges of these matters to keep an eye on what we do. Does that appeal?
So I think the long-term plan did that in terms of our service aspirations. We have to fill in the other pieces there in terms of capital, public health and people. But that standing function within government, that Office of Budget Responsibility for Health, seems to us in the Confederation to be absolutely essential. because that review shouldn't be a kind of thing you do every 5 or 10 years or when the electoral cycle dictates it. It should be a thing that's being done constantly so that we can keep pace with innovation, so that we can keep pace with the demands of a population that's living longer but is having more things going wrong with it. All of those things are absolutely, so it can keep pace with the mental health demand we're going to see from the coming recession. It's that constant appraisal of what's needed and that constant advice to the government about what investment is needed to keep pace so that the economy is as strong as possible. And I think the particularly important point that Anita made was that an investment in health and social care is an investment in the health and wealth of the nation. It's an investment in our infrastructure. It's just as important as investing in roads or HS2 or digital capability or green technologies. It's part of what makes us a competitive nation. And successive governments have failed to do that. They see it as something they do as a one-off and then they return to it 10, 20 years later. That's not good enough. It needs to be a constant process.
Danny Mortimer, Chief Exec of NHS Employers, Anita Charlesworth from the Health Foundation, and Richard Murray from the King's Fund. Thank you all very much indeed.
Thank you.
Really intriguing points there. Not all easy peasy agreement, but some fundamental stuff about redefining roles in the wake of the experience of COVID-19, but also banking them and accepting that the long-term plan is there, but it needs perhaps to have an overview body that is not of the Treasury or of the NHS, but something like the Office of Budget Responsibility that can look at it. That as you learn experiences through something as ghastly as COVID-19, you don't just shrug them off and think, right, we're back to normal next year. You learn from them, you embed them, and through that perhaps comes pretty fundamental reform. And also self-sufficiency in staff should be a long-term ambition, and progress is being made upon that. And thanks again to our sponsors, MSD, for making all of this possible,